this as big as I'm going to be able to get it. I gotta flip. Okay, so we watched the videos on all the disease processes. So obviously, just like with everything else, when we're treating, if we can understand the disease process and what takes place, like those uric acid inhibitors, then it would make, the uric acid buildup for gout. It only makes sense that something that either gets rid of uric acid or, causes excretion is going to be the thing that fixes that. So all of this should really fit together and be like, oh, okay, that makes sense. And it'll just be a matter of remembering which drugs do that. All right. So again, I already said this. A variety of drugs are used to treat musculoskeletal injuries and disorders. They include DMARDs, bone resorption inhibitors, skeletal muscle relaxants, and uric acid inhibitors. Okay, so rheumatoid arthritis. Do y'all remember what kind of disease process it is?
It's autoimmune.
Autoimmune. Autoimmune means what?
It means
the body attacks itself specifically with rheumatoid joints. So whenever I worked at Cypress Point and I did pre-op, and we would gather this information, and you would ask patients, a lot of them are there for knee replacements, hip replacements, whatever they're there for surgically. And so they would just say arthritis. Arthritis is inflammation of the joint, but we see that it can be caused, technically gout is a form of arthritis in a way, because it's just inflammation of the joint. It has a totally different etiology, and I know that we're talking about gout, but when we're talking about arthritis, we really need to differentiate, is it osteo or is it rheumatoid? Because the treatment is very different. For rheumatoid arthritis, if it's autoimmune, what body system is involved in that? The immune system. It wasn't a trick question. Yes, the immune system. So in regards to the immune system, in order to stop it from attacking, what do we have to do to it?
Suppress it.
Suppress it, yes ma'am. So if we're suppressing the immune system and we're giving these DMARDs, what do you think before you learn anything about them? If we are suppressing the immune system, what is the potential that could happen when we take these drugs? Infection, yes. So what are we monitoring our patient for?
Skin integrity.
Yes, skin, well, it's more so like infections on the skin, more so than integrity. What else? Fever, yes ma'am, what else?
That's the signs of inflammation.
Yeah, sore throat, swollen lymph nodes, all of those things. So you'll already know all this stuff. So that's good news. So they're used in rheumatoid arthritis treatment. These are the DMARDs. They are useful for their immunosuppressive ability. So that is their mechanism of action. They are also used in cancer treatment because same thing, when a patient has cancer, we need to suppress that immune response. Crohn's disease and fibromyalgia, they can be used in all of those things. Adverse reactions, when you think about them, think immunosuppressive and think cancer treatment, just for your brain purposes, because we use immunosuppressives for cancer treatment. What does alopecia mean?
Hair loss.
Hair loss, yes. And then we know that nausea takes place when we take chemo meds, just for lack of better terms to make y'all understand this better. And stomatitis is inflammation of like the oral cavity, mouth problems, sores in the mouth, all of that is related to DMARD use. And then examples of DMARDs, the most common one that you are going to see is methotrexate. The teaching point on methotrexate. I'll write it down for y'all. That's the most common one there. Is the way that it's given. It's only given one time per week. So because it's given one time per week, what is something you may need to educate your patient on? Yes, ma'am. That's the biggest thing with these drugs. They have to establish a day so they know, it's not just once a week. Because you can take something on Friday and you can take it again on Monday, And really, technically, you had it once that week, but that's not how it works. We need to either have them write it on a calendar. We need them to establish some sort of regimen so that they can take this drug correctly. All right. Oh, that didn't work. I can't reach the top. Okay. And that's not a touchscreen. Try again. Okay. Okay, so contraindications. Of course, we never give drugs if we know patients have a hypersensitivity. Methotrexate specifically is contraindicated in patients with renal insufficiency, liver disease, alcohol abuse, pancytopenia, or folate deficiency. Pancytopenia is a reduction of those counts. They already have a reduction of counts. We're not going to give them something that further reduces their counts. And then these specific medications, they are, I just want to make sure before I tell you wrong. Yes, they are biologic DMARDs. You really want to be careful with patients with heart issues. And they're found, if you wanted to look for those drugs, they're found on page 333 towards the bottom. And you know these words, you know, I kind of stink at the generic names because we never call them that. Adalimumab is Humira. Y'all have heard of Humira, right?
Yeah.
It's an eye, doesn't look like it. Enbrel, y'all seen commercials on Enbrel? And I will try to remember, or I will remember for these drugs, to put both the generic and the thank you, I appreciate y'all, because my brain sometimes gets itself. I'll put the trade name and the generic name, because these are the kind of drugs, I don't give these drugs often, so I know if you told me Humira and you told me Enbrel, you know, I know that those are immunosuppressive drugs that are given for, you know, rheumatoid arthritis and Crohn's and those kind of things. But these generic names I'm just not as familiar with, so I don't expect you guys to be. But I am going to put them both on there. And then Remicade. Y'all have heard of Remicade, right? So those are for sure be three of the ones that you need to know when I make y'all's little list. And I may have y'all match with these specifically, because most people don't know the generic names. I might get y'all to match them. So we'll think of a way to remember that. All right. Uh-oh. All right, we're going to be using these medications cautiously in patients with obesity, diabetes, Hep B or C. Patients with diabetes are already at an increased risk for infection, and they don't heal as well. So it's not necessarily that they're contraindicated. If your patient has a disease process that warrants these drugs, then of course your doctor will weigh out that risk and benefit, and they'll likely still be placed on these drugs. But if we know it's an immunosuppressive drug, and we know that our diabetic patients are, you know, they don't heal as well, you know, and wounds last longer, we really want to hammer home, like, if you have a cut on your toe, let us know. You know, we need to be aware of these things so that we can closely monitor them. So this is important to know. As far as, remember when we talked briefly, we probably should have talked about it a little bit more. Remember when we talked about the thyroid and we talked about the radiologic agents and we said, there's very specific things as related to that and caring for these patients to keep them safe and to keep their family members safe because of the radioactive material. So chemo drugs or biologics like this, not just chemo drugs, but like methotrexate and the DMARDs, they can be harmful. They can pass through the semen if people are having unprotected sex, and they can actually affect the person, that's not receiving the drug, that's not even on the medication. So that's an interesting, fun fact. Just in much the same way, breast milk. We don't want to give a baby, medication that could potentially suppress their immune system when they don't need any, they don't have a condition that warrants that. It's the same way. So that's just something that's important to know about DMARDs. And what are we using DMARDs for? Primarily? Well, rheumatoid, yes. So if I asked you a question like, my friend had arthritis and she was given Humira and it greatly improved her quality of life, but my physician won't prescribe me that, and I just keep asking them, what do y'all think might be the reason behind that?
She has osteo.
Exactly. The other friend may has rheumatoid, and this particular patient may have osteo. So those are all important things to know when you teach your patients. Sulfa antibiotics interfere. They can cause increased risk of toxicity with methotrexate. Aspirins and NSAIDs can cause increased risk of toxicity. So when we were looking at those combinations of medications, we said sometimes NSAIDs are used, in treatment of these inflammatory processes. I can't make y'all understand enough how important it is to know what your patients are truly taking. Will they never, ever, ever be on this? Not necessarily, but might they be on a decreased dosage of methotrexate? Very possible. But if your patient is on the fly taking 2 Aleve every single day and they don't tell anybody, yes, that's over the counter, but it still matters. So those are just really, really, I think I told y'all before, when I worked at Cypress, my job was so boring. It was painfully boring, but it worked for my family, and you'll make those sacrifices. And all day long, I said, this is Brittany at Cypress Point Surgical. I was just calling to collect your medical information so I can give you some instructions for surgery tomorrow. And, I would say, what medications are you taking? And after they give me their list of medications, I would very specifically have to say, nothing over the counter at all lately, no aspirin, no, and they're like, oh yeah, I take BC every day. Well, your surgery's canceled, but people don't associate over-the-counter medications with, with being actual medications because they can take them themselves when they feel like it. So sometimes they don't matter, but very often they do. Like
BC every day, birth control?
No, BC powder.
Oh.
She's like, why does that matter? Why are they canceling my surgery? Yeah, BC powder has like 875 milligrams of aspirin. It's a lot of aspirin.
And vitamins count?
Vitamins do count. So a lot of times they don't necessarily always interfere, but like it's been found that like vitamin E thins blood slightly, a little bit. Not a big deal, but if they're taking vitamin E and they're taking fish oil and they just stopped their aspirin, all of those things contributing together could potentially increase their risk for bleeding. And it's the same with many, a lot of times doctors say, oh, I worry about that, because it doesn't matter, but mentioning it is what's important, making sure that you are aware, that they are aware of all of your medications. All right, we're on something new. Everybody feels good about DMARDs? All right, bone resorption inhibitors. They're called biophosphonates. So you can have biophosphonates and non-biophosphonates. We're talking about biophosphonates first. They are on page 334. I'm sure you guys have heard of Actonel. Have y'all heard of Actonel? Resendronate and alendronate is Fosamax or Binisto. Those are your common drugs in that department. These are given, biophosphonates they act primarily on bone by inhibiting normal and abnormal bone resorption. So whenever I had y'all watch that video, we talked about the osteoclast and the osteoblast, and it was very much a give and take. You know, the osteoblast would do their thing and the osteoclast would do their thing, and that kept that homeostasis of the bone, you know, where it wasn't too brittle and it didn't have all these extra deposits. Bone resorption inhibitors are used for these things by inhibiting that abnormal. You know, they target whatever is going on and they correct it. So they're used in osteoporosis primarily, hypercalcemia, and Paget's disease. Adverse reactions: nausea, diarrhea, increased or recurrent bone pain, headache, dyspepsia, acid regurgitation, dysphagia, and abdominal pain. Make a big fat honking star. We are going to educate the mess out of these patients. These medications are usually only taken once a week. So again, it's reminding them. But they cause severe esophagitis. They cause major, major irritation, not just like a little bit of GERD, like they can erode away the esophagus if you take them and immediately lie down. So these patients have to sit up for 30 minutes at minimum after so this is not a take before you go to bed medication. This is a let gravity help us out, because we know that this can be harmful to your esophagus. Let gravity help you out, and unless you're, you know, standing on your head, normally that those gastric contents, unless you already have some kind of, you know, major GERD or reflux that's like off the charts, upright position helps it to stay where it belongs. So these patients absolutely positively need to sit up after administration. Of course, we're not giving them to patients who are sensitive to biophosphonates.
I have a question.
Yes.
The use for it, or like the action of it, can you describe that?
Let's see. We're on the previous page.
I think so. Yeah. I just like reading it.
So it doesn't actually go into a whole lot of detail. I probably showed y'all too much information about the osteoclast and the osteoblast. But basically what's taking place is the reabsorption. The bone does that reabsorption like it's a normal process for the bone. Just like breathing in and breathing out. When bone is formed, it doesn't just form when you're a baby and nothing changes. You know, it's got blood vessels. I mean, you know, it's got, the marrow has, you know, blood cells and all that stuff, and it's constantly exchanging, you know, what it needs to. So resorption takes place like whenever, I don't want to, not like great with the micro of all of it, but the medication, like the normal body process is that it's exchanging, you know, it's breaking down bone and building new bone. So if it is breaking it down too fast, then this medication stops that. If it is the opposite, if it's not pulling in enough calcium and vitamin D into the bone for that strengthening, then it helps in that way. So basically it just acts by inhibiting the normal and or abnormal bone resorption. So it is kind of like a corrector, you know, kind of like a give and take kind of thing. As far as the exact like major mechanism of action, I don't think it goes into that, but let's see if I can give you a little bit more. It says approximately 54 million Americans have osteoporosis, which is porous bone or low bone mass. So they, you know, those networks within the bone are either, it looks more like cottage cheese instead, not cottage cheese, Swiss cheese with like big holes instead of like little small baby Swiss. So osteoporosis involves bone loss seen typically in postmenopausal women. It's estimated that 700,000 spinal fractures and 300,000 hip fractures occur yearly because of the disease. Biophosphonates and newer biologic drugs are helping to reduce these fractures. Biophosphonates act primarily by inhibiting normal and abnormal bone resorption. This results in increased bone mineral density, reversing the progression. So it's just pulling in the stuff it needs, and it's just kind of regulating that in a way. It doesn't go into a whole lot of specifics about that. But if you're the person that like, I kind of like to understand stuff at a deeper level because it kind of makes it make sense, I'll look that up for you.
Well, just you describing that helped a lot. Just me reading it, I didn't process.
Yeah, it doesn't go, normally like when we talked about, so when we talked about antibiotics and we're like, it destroys the cell wall, and it was very specific on what it did. Your book really doesn't go into that, but I'm quite sure there's specifics. I just don't know. They do a bone density, and they also do a, there's another text, hold please, let me think of it. Bone density tells how dense those bones are. Does anybody know it offhand? There's another test.
This is gonna sound silly, but is it something to do with water?
I don't think so.
Like you.
I don't think so.
I'm like,
You float better.
With
osteoporosis.
buoyancy.
It's a very specific, a DEXA scan. I didn't even find it yet. DEXA scan.
What is
What's
it?
DEXA scan, you are going to ask, let me finish. Okay, it's a high precision type of x-ray that measures your bone mineral density and bone loss. If your bone density is lower than normal for your age, so bone density is the first thing that's checked. If it's lower than normal for your age, it indicates a risk for osteoporosis. DEXA stands for dual energy x-ray absorptiometry. So it's just a further look at those bones.
What is the range for bone density?
Y'all killing me today. No, I love these questions, but I'll be lying if I told you. I'll look it up.
We're hungry for knowledge.
I love knowledge. Normal bone density is a T-score of -1.0 or above is normal bone density. Examples are 0.9, a T-score between -1 and -2.5 means that you have low bone density. So it looks like -1 or above.
So you're going towards 0?
Going up towards 0, the higher the better.
Okay.
The negative, the more negative. So it looks like a -1.0 is normal, but lower than that, so like a -1.1 would be too low.
Okay.
Any other questions that I probably don't know the answer to? Bring them on.
How did I test bone density?
Y'all are, I don't know.
Okay, I have to do that.
I'll be happy to.
It's like a thing.
I think it's
It's
a,
like a plant that looks like this.
is that terrible? I have never worked in that department. Let's see.
No, that's.
All beautiful questions. I want y'all to ask this stuff. How do they, and I probably should know some of it, but I don't.
That's when they float in water.
No. A bone density test uses x-rays, so regular x-rays, to measure how many grams of calcium and other bone minerals are packed into a segment of bone. The bones that are most commonly tested are the spine, hip, and sometimes the forearm. Very interesting. So like, when they do an ultrasound, this is just what makes me think of, when they do an ultrasound and they measure, and they can measure from this location to this location, and make a little, it sounds like they do the same thing in that way, to determine how many grams of calcium and.
Or like they take a little spot of your bone
Yes.
and count how many and then estimate how many.
Yes, that's what it sounds like. But we can totally watch. I think the better truly, this is not the area, like when we start talking about pain meds, I worked in pain management, so I kind of like that and talk about it a little bit more. And I'm a little bit more knowledgeable. But anything like this, when we have time, the better understanding you have of like the basics, it just makes it make so much more sense. It really, really does. That's what I told, now that I'm an educator, I want to go back and take another micro class and another A&P class, not to torture myself, because y'all know good and well when you're learning that you kind of just learning it to roll out.
Yeah.
Like nobody's like, or I say nobody, most people are not like, doing toe touches because they're so excited about it. But now that I see how much it impacts all the other things, I'm like, I want to go take a class, but guess I'm weird.
Rheumatoid arthritis, how is that diagnosed? Is that an X-ray?
Rheumatoid is, there's a lot of stuff that goes into that. It's gonna be those immunotype, it's called an immuno, ASSAY, and it's gonna tell there's certain things like the C-reactive protein,
Okay.
and all of these things will be elevated in blood work, and then they'll further do some specific, immune-specific, like y'all remember learning about, I do know this, let me think of the name of it. Whenever a patient has allergies, and they do like the immunoglobulins and the GABA globulin, you know what I'm talking about, and they do like that allergy panel. It's a similar type thing in regards to seeing if their immune system is overactive, and then that'll give them, if their immune system is overactive, then they can test stuff to check their inflammatory response, and if that's overactive, then all of that stuff, in addition to the x-rays, that are showing inflammation on the joints and all that, kind of goes together for that diagnosis.
Could rheumatoid be genetic?
Oh, yes, it can be. Lucky.
Several people in my family have rheumatoid.
It can be, were you taking notes?
Yeah.
Oh, I'm sorry, you can take.
I have them in my, like earlier I already stuff down in my notes.
Okay, that's fine, I'm sorry. So whenever you are, I apologize because I interrupted and I don't remember what I was talking about. Genetics. So a lot of times those autoimmune diseases are genetic, but it's not like if your mom and your grandma have it, you absolutely 100% are gonna have it. Like, it's not like that. But they sometimes do have a genetic trait that goes along with them.
Is there something you can do to prevent it?
Not usually, no. It's kind of usually one of those things if you're prone to it. The earlier it's diagnosed and you can kind of get on top of treatment, before the goal is to get into treatment before that fusion takes place. Because once that bone fusion begins to take place, then that's when you have the deformities of the fingers, and you really can't, y'all seen people with like way deformed fingers, like not just,
Sideways.
yeah, not just like, they usually have rheumatoid.
There's a lady at that her hands were like up.
Yeah,
She couldn't move this joint.
this whole joint, yeah.
So like they were just stuck straight like this, and she kind of was like that flawless. She could move her thumbs.
Yeah, and then there's juvenile arthritis, and it's usually of the rheumatoid type, So sometimes people will have that from a very young age. And people should, usually if they don't know that they have rheumatoid, then they have regular arthritis. So that's what I was saying earlier when I was at Cypress and they would say, hey, I have arthritis, and we would say rheumatoid or osteoarthritis. I don't know. Usually if you have rheumatoid, your treatment and it's more, you'll usually know. You will have been diagnosed. It's not something like you just throw around like your doctor's like, oh, no, you probably have rheumatoid. No, you've had a specific battery of tests that indicate that you do have rheumatoid arthritis.
Another question.
Yes.
Can popping your fingers actually cause arthritis?
I'm 99% sure that is a myth.
Okay.
I've heard that all my life. We'll have to debunk it for sure and do some myth busting.
Yeah.
It should not affect, the whole issue is the synovial, unless for some reason you're doing it so much and that synovial fluid is like disappearing, but to my knowledge, I'm 99% sure that's a myth, but we'll check it out.
Well, they know that I watch a lot of chiropractic videos, and in all my videos, the patient asks at least once, like, does popping your fingers cause it? And she says no.
Yeah, I was 99, but I never want to be the person that's like 100% no.
Does, like regular arthritis, like is that like
So it's not necessarily, we are predisposed to a lot of things, but it's really all about your specific joints, and the amount of fluid that you have. It's kind of, it's not like a huge genetic disposition, But a lot of times, just in most conditions, if your mama had it, then you're at more risk for it, for most conditions. But it's not like a for sure kind of thing. Even with rheumatoid, it's not a for sure. You're just a little more predisposed to it.
So is normal arthritis osteoarthritis?
Yes, normal, for lack of a better term, just regular old age arthritis is osteo. And rheumatoid, the big defining difference is that rheumatoid is autoimmune. Good questions. I like questions. They make me sweat a little bit. We talked about this already. So just to clarify, since we have, because we were talking about arthritis, bone resorption inhibitors are for osteoporosis, not arthritis. But we had kind of moved on and then backtracked. The current slide is for people with osteoporosis. All right.
I think we went over that slide.
I think I did too. Thank you. Okay. Alendronate and resindronate are contraindicated in patients with hypocalcemia and pregnancy. Biphosphonates, here we see it again, are contraindicated in patients with delayed esophageal emptying. Why?
Because of,
You know what you were about to say.
because of the regurgitation.
Yes,
Okay.
because it causes that esophagitis. So if the patient already has an issue there, we absolutely positively don't want to make that worse. All right. So calcium supplements, antacids, and magnesium and aluminum, all of those things can decrease the effectiveness of biphosphonates because in the stomach, they can, that acid-base balance, and they can kind of cancel out these medications. Aspirin can cause an increased risk of GI bleed. We said that they potentially can erode the esophagus, which means they're not great on the stomach. Stomach is a lot tougher than the esophagus is, so it can handle that low pH level. But if we're taking aspirin in addition to, and we're causing some irritation and regurgitation in that upper part of the esophagus, if we're taking that, then and we're eroding a little bit, and we're taking aspirin on top of that, then our risk for bleeding is increased. Theophylline, y'all are starting to see that a lot, right? So far, it interferes with a whole lot of our medications. All right, the end on biophosphonates. Okay. Skeletal muscle relaxants. Y'all heard of muscle relaxers. We don't say, the doctor prescribed me a skeletal muscle relaxant. We say, this is a muscle relaxer. Same thing, y'all. So, those are found, I think they're the first section.
325.
On page 325.
Yeah.
Okay.
For the chart, they're on 37.
Oh, that's what I was a little confused.
Oh,
That's what I was
yeah,
looking
sorry.
for.
My bad. I was looking at the section.
So y'all have probably heard of a lot of these medications. Baclofen, have y'all heard of baclofen? And cyclobenzaprine is a very common one. Soma is not as common as it used to be. Soma was noted to cause a lot of, it was often being prescribed with pain medications, and it caused a lot of drowsiness and a little bit too much CNS depressant. Y'all have heard of Valium, diazepam, and y'all probably have heard of a lot of these. Methocarbamol, which is Robaxin, and tizanidine, which is Xanaflex. These are some other medications that I would like y'all to try to remember, especially Valium, Xanaflex, and Baclofen. Remember those generic names of those medications. Yes, ma'am.
I think my mind just keeps going to things that are totally unrelated to this. Would icy hot be something like a muscle relaxant?
So no, but good question. So icy hot, it kind of completely different mechanism of action. It's more of a topical, and we're going to talk about that when we talk about pain relievers. We use it for tense muscles, but it's more of a topical, like it's got menthol in it, so it's like a topical kind of cooling, it's got a little bit of numbing, cooling stuff in it. So not in this section, but we will talk about that in something that's used with, it'll often be used with muscle relaxers because it doesn't have a systemic effect. So we'll do that topical business, and then we'll give them, you know, something systemic as well.
But these are systemic?
These are systemic, yes. So muscle relaxers, they are used for various acute things. They're usually not used, unlike the other stuff that we talked about, for long periods of time. Unless you have a major chronic condition, doctors try to stay away from these and use them more for acute cases. They cause a lot of drowsiness. Uh-oh. How come whenever I want to flip that, it won't flip? They cause a lot of drowsiness, sedation, sleepiness, bradycardia, lethargy. If it causes those things, what is happening, guys? Where did it even go? Oh, man. Okay. If it causes those things, I want everybody to tell me together what we are worried about. Yes, we are worried about safety. So if these are the side effects, then we are absolutely worried about the safety of our patients. And we're worried, we're going to talk about it more. Drug combinations are dangerous. So a skeletal muscle relaxant, when you're not really taking a lot of other things, you're not, as young people, you okay?
Yeah. Me?
Yeah, I thought you
There was a hair.
I thought you were having like a, I don't know, you looked really concerned.
There was a hair. I thought it was in my mouth.
So patients who are taking these are often not just on these. They got a muscle relaxer for, and this is not always, but these are our things that we think about as a nurse. They got a muscle relaxer for a car accident that they were in 2018. They were prescribed for something acute. They took them for 3 days and they felt better. Well, they got into another car accident. You know, they kept them in their cabinet, 2 years later. They got into another car accident or a swimming accident or whatever, and they're like, oh, my back feels the same way it did whenever I got into that wreck. So they go ahead and go get them some medication from the ER, and, they're prescribed a mild pain medication. Like, let's just say, I don't know, they try not to prescribe a lot of that stuff in the ER anymore, but this is why. So they go get a mild pain medication, and they come home and they take a lower tap 5, and it's not really working too good, and they remember that they have those muscle relaxers. And then they go grab some muscle relaxers that were prescribed to them, but they self-medicate. Those pain medications cause a decrease in respiratory rate and a decrease in all of this stuff. And then these medications cause sedation, and sleepiness and lethargy. Within your patient, their respiratory rate is down, and they're at home all by themselves because they really weren't trying to overdose or anything like that. And they use those medications together, and it makes them dangerous. So muscle relaxers cause all these things, but muscle relaxers become more dangerous when combined with other drugs that cause similar CNS type effects. Does that make sense to you guys? So no, again, not everybody that's on both is not going to wake up. I don't mean it like that, but y'all understand what I'm saying. Those are the kind of things that make these meds dangerous.
I'm prescribed muscle relaxers, but I don't like them too much.
Do they make you really sleepy?
Yeah, like, cause I have osteoarthritis in L4 and L5, so I have to take them sometimes whenever I get like a bad, like I'll sleep wrong or something, and then like I'll wake up like I can't move.
Uh-huh.
So like I'll take them in those instances, but I don't like to, cause they make me really sleepy.
Yeah, they affect a lot of people like that, where it's almost, and that's why people start to get in the pain management world where they just start to get defeated too, because it's like, well, I can feel better if I take this, but my whole day is
I
shot.
feel like I can move.
Yeah, you feel 100. Physically, you feel better, but mentally, you feel like crap. And so we're going to talk about that coming up too. It's like you get into this like, I can feel better and sleep all day, and then it becomes like this whole depression issue, and then it becomes this whole, you know, I don't want to be dependent on these, and it just becomes a whole snowball effect of, is feeling better worth these adverse effects? And that is very specific for every single patient. Yes.
For people who are prescribed this and there is like a high addictive rate or whatever, what is it that is causing them, like, why would they be addicted to something that's just causing them drowsiness?
So it's different. So remember, we have those different medications affect, and again, I'm not like top notch on them, but a lot of these medications are affecting the central nervous system. And when we start messing with the central nervous system, we start messing with, like, oftentimes when you trade one neurotransmitter, you get less of this and more of this. So like dopamine and serotonin, it kind of starts a little tug of war with like your pleasure feelings. And it might be like, oh, I feel better. So it's more that feel better that they're reaching for than that, oh, I'm sleepy. You know, some people want to sleep their life away, and because they don't want to worry, you know, they already have depressive tendencies, and they, you know, all of those things are not issues, but, you know, all of those things are predisposing them. But some medications, because of those exchanges in the brain, they just, remember we talked about like the very first week, the schedules, and we had Schedule 1, Schedule 2, Schedule 3. Some medications just have a higher, doesn't mean everybody that takes it is going to be addicted to it by any means, but they have that higher potential for abuse. And it's like a combination. When we do medications, y'all are going to really like the pain chapter. We're going to watch a lot of videos on how this stuff happens and how there's a difference between, you know, drug whenever you're dependent, like psychological dependence versus, you know, physiological dependence. And we're going to talk about those differences. These medications, like your baclofens and your cyclophosphamide, don't have nearly as high potential for abuse as do your benzodiazepines. Valium and Valium's the only one on here, but like Valium, lorazepam, those LAMs and PAMs, they have a higher potential for abuse.
Yeah, the cyclophosphamide is the one.
Yeah, and if you probably have had, you're probably fine taking it and not taking it again for 6 months. It doesn't have a super, so not all, actually I'm glad y'all brought that up. Within this skeletal muscle relaxants, that's their big umbrella, but some of them are benzos, some of them are non-specific drugs. They're not all, they don't all have a high potential for abuse. And I can break those apart for you guys. Just if you like to know that kind of stuff, but not everything in this. If I change that to a test question and I said, you know, the doctor gave me a muscle relaxer and my aunt got a muscle relaxer after a car accident and she became dependent upon that muscle relaxer, and now the doctor gave me cyclophosphamide and I am fearful that that might happen to me. Those are some of those education of, you know, not all skeletal muscle relaxants have a high potential for abuse. It depends upon their schedule, you know, and it depends upon that. Just for kicks and giggles, I'll look up the schedule for cyclophosphamide. It's a pretty low schedule drug. I mean, a pretty high schedule. It doesn't have a high potential for abuse. The higher the schedule, I mean, the higher on the list, like a Schedule 1 drug has a very, very high potential for abuse, whereas a Schedule 5 drug does not. Let's see. What schedule is? Okay, so cyclophosphamide is not currently controlled under the Controlled Substances Act, so it's not even on that chart. So it does not have a high potential for abuse at all. Whereas, let's see what schedule Valium is. I want to say it's a Schedule 3. DEA scheduling. This is Schedule 4, but it is on that list. You know, it is on that high potential for abuse list. If it makes it to that list, it's worth mentioning. Like Adderall is on that list, you know, different things like that. But cyclophosphamide then aspirin's not even on there. So that was actually a really good question, so that y'all aren't all like, oh my, you know, if I'm prescribed these drugs, they're dangerous. Let's see. So baclofen is contraindicated in skeletal muscle spasms caused by rheumatic disorders. Cyclopin aspirin is contraindicated in patients with recent myocardial infarction, cardiac conduction disorders, and hyperthyroidism.
Classified recent as like within the last year.
As far as what, I'm sorry?
MI.
Usually recent is 6 months. You know, when it's used recent, it's usually referring to a 6-month time period. That is very vague, though. Those are the things like, if you know recent, then you can always dig a little bit more. And those are the questions that you ask. So he had a MI 8 months ago. You feel good about this drug, you know. All right, we're going to use them cautiously with patients with a history of CVA, cerebral palsy, Parkinson's, or seizures. Several of the skeletal muscle relaxants are, you know, CNS drugs. So it would make sense, you know, why we're going to use them cautiously in patients who have had cerebral incidents. And I kind of already told you guys this. So skeletal muscle relaxants as a whole, you know, they all have that different class that they're in, but CNS depressants such as alcohol, antihistamines, opiates, and sedatives can increase that CNS depressant effect. So that's what I was telling y'all. In and of themselves, not incredibly dangerous, but combined with alcohol, combined with all of these other things, they can become dangerous. Y'all starting to see MAOIs a whole lot. When I think MAOIs, and I think, and like this is just for me, when I think MAOI and theophylline, my very first trigger that goes off in my brain is drug-drug interaction. That probably would be good for y'all to think of too. Like when you start drawing for straws on NCLEX and, and you're like, I don't remember any drugs that are in this drug class. Know that those are those high, digitalis too. Digoxin is another one of those drugs. Haldol, y'all haven't learned about Haldol. So with tizanidine, CNS relaxant, you know, CNS depressant, and antihypertensives. So antihypertensives are going to cause hypotension, and then CNS depressants cause a little bit of hypotension. And so those things combine together, even though you may not specifically say this plus this is a bad thing, you can kind of rationalize why it is. All right, and then gout. New subject. Feel good about muscle relaxants? We watched that little video, and for those who are not with us, I'll post it. So gout is, uric acid inhibitors are going to decrease. We know gout is caused by the collection of the uric acid. The uric acid makes crystals. The crystals cause that inflammatory response. So the whole idea is to prevent these acute attacks. Adverse reactions include GI reactions, nausea, vomiting, diarrhea, and abdominal pain. Colchicine is for patients, it's contraindicated in patients with serious GI upset, renal disease, hepatic disease, cardiac disorders, and those with blood dyscarrias. And then probenecid is contraindicated in patients with blood dyscarrias, uric acid kidney stones, and in kids younger than 2. We're going to use them all very cautiously in patients with renal impairment. And allopurinol, when y'all write that down, if y'all want to put A, L, make those L's big, it is really bad for people with liver problems. Allopurinol. We have to use very cautious in patients with liver impairment. See that theophylline again? Allopurinol and theophylline do not go together. Ampicillin plus allopurinol can increase the risk of a rash. Same with these antibiotics. They can increase the serum level of the antibiotic, and because that serum level is higher, those patients are at an increased risk for those adverse effects of the antibiotic. Does that make sense? All right. All right, that is all the info. This stuff, y'all should know. So I'm going to ask y'all questions. We're not going to talk about the nursing assessment. Y'all are gonna tell me. Yes, ma'am.
It may be a dumb question, but why like allopurinol and all those drugs, like why do they specifically have like liver problems or stuff like that, even though they have the same mechanism of action?
You know, a lot of it has to do with, y'all, we learned about that absorption, distribution. A lot of times if they are most stuff is primarily metabolized by the liver and excreted different ways. Usually if they are increased risk of like hepatotoxicity, they are more, it has to do with their metabolism and excretion. The more so, not the mechanism, but more so the way the body uses it and gets rid of it. Does that kind of make sense?
Yeah.
Questions? All good? Okay, so as far as if you were assessing your patient for osteoporosis, forget about this, we're talking assessment. Tell me stuff that we are gonna look for. What is something we're gonna ask our patient if we're assessing them? Pain. What else?
Range of motion.
Okay, so actually, we're talking osteoporosis. Tell me why pain.
Because inflammation.
Wait, time out, osteoporosis. I'm glad I asked you that. So they might have pain, but it's not related to the inflammation. Osteoporosis doesn't have anything to do with inflammation.
Because the bones are rubbing together.
Okay, so osteoporosis is more about the density of the bones, which makes them at risk for breaks. So you would start more with, have you had any breaks recently? How many breaks have you had in the last such and such? Now, pain would come into play more of if they fell and broke something and didn't know it. You know what I'm saying? Like, but not about the inflammation. So I'm kind of glad you did that, and I'm not picking on you at all. Whenever y'all are answering your question, don't just think, we talked a lot about inflammation today, but osteoporosis really doesn't have a lot to do, it doesn't really have anything to do with inflammation. It has more to do with the density of those bones. So what else related to osteoporosis? What are some things that you might gather? Thinking about bones.
Generalized weakness.
Yeah,
What you're good for.
maybe think a little bit more.
Like calcium, like the diet.
Yes, that's what I was looking for. Absolutely 100%. You know what? How much calcium are you taking in? If you're drinking 17 glasses of milk a day and you're still breaking a bone every other day, we have a disconnect there. Absolutely perfect. What else? Those are the biggies. So we'll move on from osteoporosis because the rest is just kind of secondary to that. Getting specifics on their diet, getting lab results for vitamin D and calcium. I keep wanting to say vitamin C. It's like that's stuck in my brain today. Vitamin D and calcium. Okay, when you're assessing your patient who has arthritis in general, tell me things you would ask them. Any swelling of the joints? What'd you ask me? What'd you say?
Pain.
Pain.
Inflammation.
Inflammation.
Like if you're having on the symmetrical side.
Beautiful. Is it just which joint? Is it all my joints hurt, or is it, man, my left knee is killing me and my right knee is okay? What else? That's what I was looking for. Movement. What is their range of motion like? Is it interfering with their everyday life? So those are assessment things in regards to that. Gout, we've kind of already talked about. It has to do with inflammation, but again, is it interfering with your daily activity? Does their foot have a deformity? Is it looking different?
So is it really only in the big toe? Or is
So
it
good
more
question.
common?
It is not, 90% of gout cases are in the big toe, but not all.
background, really lost.
Not all gout is in the foot. You can have gout of your knee, gout of your elbows, any joint, hand. The toe is that tophus joint, whatever it's called, I don't know what it's called. 90% of cases are there.
Well, we were talking about the one with pain, range of motion, functional size. Which one was that? Which one?
That was just arthritis in general, like the big picture inflammation of the joint. So technically, at the end of the day, gout is inflammation of those joints, but it's caused by something different. It's caused by that uric acid buildup and those crystals built up, in that joint.
Okay.
But so technically, it's truly not, like arthritis is a super vague term. Arthritis just means inflammation of a joint.
Okay.
It can be related to a million different things. So I was just asking about arthritis in general, which could include osteo, rheumatoid, whatever. Rheumatoid arthritis does not just affect the joints. Y'all heard him say that it could affect other body systems, other organ systems.
Just about every other body
Yeah.
system.
Yeah.
Yes.
Skin part.
Yes.
Yeah.
All right, so assessment, y'all know assessment, right? So in regards to, so diagnosis, what are some diagnoses that might be for your patients? They can be specific to the meds or just specific to their disease process. Safety risk, which would be related to the medications.
Risk for infection.
Risk for infection related to
Immunosuppression.
the immunosuppressive medications, very good.
Education on scheduling.
Yes, like risk for non-compliant, I don't know the exact nursing diagnosis, but risk for, non-compliance related to the medication regimen. Y'all know this stuff already. I feel like all these last slides, y'all know that stuff. You just have to apply it on your exam. So let me stop my recording. Good job.